Blood Bank Guy Essentials 006. I had the experience not too terribly long ago of sitting across from one of my peers. I respect her enormously, and we were debating this very issue. We were doing it in front of some residents, and she didn't agree with me. She told me basically that I needed to be a nicer person. She's probably right about that. Hi, everyone. Welcome back to the Blood Bank Guy Essentials podcast. My name is Joe Chaffin, and I am your host. We will get to today's guest in just a second. Trust me, he doesn't mind waiting. He's kind of a buffoon. You don't mind. Just keep him waiting for a while. But first, before we get to him, I wanted to just thank you for the response that you guys have had to the podcast. It's been really overwhelming for me to see in the last month since I launched the first podcast right at the beginning of April 2016, how much of a response there's been. A large number of downloads, several thousand downloads have occurred of the podcast. You've actually put the podcast on the front page of the new and noteworthy section in iTunes for science and medicine category, which is amazing to me to see my weird looking face up there in iTunes. I've gotten lots of great email and Facebook and Twitter feedback also, which has been really gratifying. I'm grateful that you're seeing what I'm trying to do with this podcast, which is really just to get useful information to you, useful educational material to you in as simple and regular a way as I possibly can. I would ask you, if you do have the opportunity, next time you're in front of your computer, if you're an iTunes user, just please go to the Blood Bank Guy Essentials podcast on iTunes and just give us a rating. That's a star rating, a review, just a brief written review to tell other people what you think about the podcast. And if you can, to subscribe to it as well. Really what that helps to do is it just, again, gets the podcast in front of more people. And I'd really appreciate it if you have the chance. I also started about a month ago the Blood Bank Guy Essentials blog, which started really the same day, basically, as the podcast. And again, it's been fairly overwhelming to me how many people have this has seemed to connect with, I should say. The blog is found at the Blood Bank Guy website, bbguy.org/blog. I've gotten tons of terrific feedback, again, through all those same channels that I mentioned before, email, Facebook, and Twitter. So thank you very, very much for that. I also appreciate your patience as the redesign of the website is finally done. And there are things that are not on there yet that will be shortly. I promise you I'm working furiously on them and will get them to you as soon as I possibly can. So again, forgive the delay there, but it is coming, I promise. I will continue to send out educational material like this on a regular basis. And I have lots of exciting stuff coming over the next 6 months or so, including some new webinars, some new online courses that I'm working on, as well as ebooks. So please stay tuned and I will keep you posted on all those things. And if you're interested, you can go to the Blood Bank Guy website and just sign up for my email subscription list. It's free. I'm not going to spam you. And again, it'll keep you posted on things that are going on. So that brings us to today's guest. Today's guest is a guy I've known for quite a long time. He's a weirdo, a freak, a educational buffoon. He's me. I am today's guest on the Blood Bank Guy Essentials podcast. About once a month or so, I'm going to do a podcast just like this, where it's just me talking to you. I call these the Ask the Blood Bank Guy podcast. It really is just a mailbag, basically, where I take emails and messages that you've sent through Facebook and Twitter. Just use the hashtag AskBBGuy, and I will get them. I will look at all of them, and I will use some of them on this podcast to just answer questions and give you guys just a basic overview on some things, again, with the idea being to just give you things in as simple and straightforward a way as possible. Okay, here is question 1. It comes from Twitter, and it comes from Hemovigilance Guy on Twitter. Hemovigilance Guy is from Australia, so he spells it properly, Hae, and his Twitter handle is awesome, Hemovigilante. Wonderful. Anyway, he says on Twitter, I'm interested in your thoughts on terminology for weak and partial D as per Daniels in 2013 British Journal of Hematology paper. He suggests that we use variant for both. It's a great question. It's a quick question, obviously. 140 characters limits you in terms of how much you can say, but it really raises a lot of different possibilities for discussion. This question came in response, in parts, to the last episode of the Blood Bank Guy Essentials podcast 005, in which I did an interview with Dr. Connie Westhoff. Dr. Westhoff and I discussed the use of Rh genotyping and people testing in a particular way on routine serologic D-typing. So I want to take just a few minutes to review it, just because I know how difficult this is for people that are just getting going in blood banking, and really even for people that have been around for a while. So let's talk about D testing. So testing for the D antigen, which you may know in a different way as Rh grouping, it's a really routine part of blood typing, and the vast majority of people have very simple and straightforward D testing. In other words, the modern anti-D reagents that we use are generally a mix of a monoclonal anti-D, which is usually IgM, and a polyclonal or anti-D, which is usually IgG. That mixture generally is extremely powerful, extremely sensitive, and just about everyone that carries the D antigen, in other words, somebody that's Rh positive, will test strongly positively. And if you're doing that testing in test tubes, they'll test that way right away at immediate spin, as we call it. And it's also very strong on the automated platforms like gel and solid phase. People that are D negative will be D negative, and no mystery, no problem, no big deal. However, a number of years ago, we actually discovered that there were a small number of people who tested just in a unique and odd way on their anti-D testing. So one group would appear to be D negative on that immediate spin test, but if we looked more closely by using anti-human globulin reagents, we actually saw that they actually were D positive, because the anti-D was still stuck to the red cell, still sticking to the D antigen, and we could prove that later on. It just looked like they were D negative on the initial immediate spin test. We called that initial finding, we called that the DU, that's D with a superscript of U phenotype. We don't use that terminology anymore, but the DU and subsequently weak D phenotype, as we now know it to be, was thought originally to just be a quantitative issue. In other words, they had the D antigen, they just didn't have enough of the D antigen. So file that away, and we'll talk more about that in just a second. But as time went by, we found some more strange things. There were some other people that would test positive. They would also test positively, but not nearly as strongly as they should have. In other words, the testing that I mentioned to you before, routine D testing, people who really are D positive are usually super strong and obviously D positive. They'll be 3+ or 4+ in most cases on the 1 to 4+ scale of agglutination. So it wouldn't be mysterious. They're strongly positive. However, we found a small group of people in the range of less than 1% to about 1%, where that testing was much weaker. In other words, it was about 1+ or 2+, or to put it a different way, as Dr. Westhoff mentioned in last week's podcast, it is weaker than expected, according to the package insert. We call those individuals now serologic weak Ds. Well, before that, we actually discovered a whole new category. Actually, it was after the DU and before we really appreciated most of the serologic weak Ds. There's another group that these people appeared to be D positive. They tested positively. Yeah, they looked completely D positive. But when we transfused them D positive red cells, they would form an anti-D. And that's just weird, right? It just doesn't make any sense. They are D positive. You give them D positive red cells, they form anti-D. More investigation of that revealed that these patients appeared to have some kind of a problem with the actual structure of the D antigen. In other words, they have the antigen, but it just didn't look quite right. Technically, we would say that the antigen had some missing or abnormal epitopes or antibody binding sites, or as I loved the way Dr. Westhoff put it last week, bumps on the surface, just an abnormal appearance to the surface of these cells. Over the years, cells like this went by several different names. Things like category D and D mosaic were names that we would hear. Nowadays, those cells are called partial D red cells. So for years, we had these two unusual D phenotypes, weak D and partial D. Truth be told, there were more than just those. The most famous additional one was one called DEL, or DEL, which is basically a super weak D that you have to elute the antibody to actually find it there. But that's not what we're going to talk about today. We're sticking to weak D and partial D. And because we really like to keep things as simple as we can, we tried to keep weak D and partial D in their neat little boxes, and the boxes looked kind of like this. When we talked about structure, we would say that weak D had normal structure, just not enough D antigen. Partial D had abnormal structure or missing epitopes, but generally speaking, a relatively normal quantity. In terms of the risk of this individual making anti-D, if they were given D positive red cells, traditionally we would have said with weak D, really not much, if any. With partial D, that risk is definitely present. Further, something that actually hasn't changed in recent years is what do you call one of these patients if they're a blood donor? And this is absolutely true, and this hasn't changed and probably won't change, is that either weak D or partial D donors should be called D positive. So anyway, with those two neat little boxes in terms of structure and the risk of making anti-D, we really didn't take all that long before we found that those boxes just didn't reflect reality. In particular, advances in molecular testing showed us that both of these unusual D types were caused by specific genetic changes, and we kept finding more and more and more and more of those changes. Some of the changes, though, broke down the barriers because we started to see some people with weak D that were making antibodies when they were exposed to D positive red cells, and we saw some partial D people that had smaller quantities of D than expected. In other words, we saw a significant overlap between the two categories, and it started to get really messy. So what Jeff Daniels talked about in the paper that was mentioned in the original question, feels like forever ago, was that the terminology, in his words, was inadequately defined, and that, quote, the terminology used to describe these variants is actually misleading. End quote. He suggested, and really he wasn't the first to suggest, that weak and partial D should just be replaced. Just forget it. Just don't try to figure it out and call them all D variants. So functionally, the question that was asked of me was, what do I think about that? Well, yes, I think that's completely fine. I think that the protocol suggested in Daniel's paper and further defined in the work group that Dr. Westhoff described in the last podcast is more than sufficient. And really, we shouldn't get that hung up on terms and labels anymore. Really, the most important distinction is that individuals who have weak D types 1, 2, and 3, those are the people that should fall into a different category than really all the other forms of weak and partial D. There's plenty of evidence to conclude that weak D types 1, 2, and 3 do not make anti-D when they're exposed to D positive red cells, so they can be treated as D positive when they're recipients, while all the other patients with D variants are really best treated as D negative when they're transfused or pregnant. Be careful with that last part that I just said, because Dr. Westhoff pointed out in the podcast where she was discussing this last week that not all D variant people necessarily have to receive D negative red cells when they're transfused. It's primarily limited to those who are going to be chronically transfused. But either way, whichever way you go with it, unfortunately, you have to understand that the only way to really prove this, that a patient is weak D types 1, 2, or 3, the only way to do that is to perform Rh genotyping. And while there's been a really broad recommendation to do so for patients that are testing with that serologic weak D that I mentioned earlier, I have not yet seen the practice become widespread. So the short answer to your question, hemovigilance guy, is yes, I'm totally fine with it. Yes, it makes sense, but it's not quite as simple as that. Okay, the next question is a transfusion practice question. It comes from Dee in Colorado, and she asks, I have a few questions about using Group A liquid plasma that would have a 26-day out date. We would use it in place of AB plasma in trauma situations. What are your thoughts on this product? Is it FDA approved? Under what circumstances is it an appropriate product? And if you used it, would you need to supplement for decreased levels of any of the coagulation factors? Now, full disclosure, the person who wrote this, Dee, is one of my favorite people on the planet. She and I worked together at a previous stop in my career, though I did not ask her to write this question for the podcast. It just worked really well. So let's talk a little bit about liquid plasma. And liquid plasma, that's capital L and capital P, liquid capital P plasma, has been called by several things over the years. Never frozen plasma, 26-day plasma, some people call it. It is not a new product by any stretch of the imagination. It's been around for a long time, but it is gaining new attention in recent years. It is, in fact, an FDA-approved product, and really in the United States, its preparation is really simple. here in the US, the plasma product is just separated from a whole blood collection, placed in storage at 1 to 6 degrees Celsius, and that time frame for storage is a period up to 5 days beyond the expiration date of the original whole blood unit. That's a lot of words, so stick with me on that. So in other words, if you collected a unit of whole blood, the time at which that unit of whole blood would expire if you did nothing else to it, you can keep the liquid plasma for 5 days beyond that. Now, in the United States, most whole blood products are collected using either citrate phosphate dextrose, which is CPD, or the same anticoagulant preservative solution with double the amount of dextrose. We call that CP2D. So with either of those two anticoagulant preservative solutions, both of those would give a whole blood unit a shelf life of 21 days. So as a result, add 5 to that, most units of liquid plasma, capital L, capital P, expire 26 days from collection. Now, you should know that a few centers still collect whole blood in CPDA1, citrate phosphate dextrose adenine 1, which is a different anticoagulant preservative solution, gives you 35 days of whole blood shelf life. So FDA has approved liquid plasma from CPDA1 for up to 40 days of storage. But I'm going to stick with the 26-day because that's what the vast majority of places in the US are using. So in the United States, we have a package insert for blood. You may not be aware of that. Like with other drugs and things that you're buying that are prescribed by a doctor, the FDA requires a package insert. Well, you know what? So does blood. The blood package insert, if you will, is called the Circular of Information. It's jointly published by the AABB, American Red Cross, America's Blood Centers, and the Armed Services Blood Program. And in the November 2013 version of the Circular of Information, and this hasn't changed for a while, it simply states that liquid capital P plasma, I put the capital P in just to remind you, liquid plasma is indicated for the initial treatment of patients who are undergoing massive transfusion because of life-threatening trauma and or hemorrhages and who have clinically significant coagulation deficiencies. So what does that mean? As the use of plasma has increased in trauma and massive transfusion settings in recent years, and it's done that largely in response to for the desire to keep the number of red cells and plasma units transfused as close in number as possible. The trauma surgeons and the blood bank literature will describe that as a 1-to-1 ratio. Anyway, as we've tried to do that over the years, it's become more and more difficult for transfusion services to keep up. Let's be honest, there's really just no way for a transfusion service to just yank units of frozen plasma out of the freezer, thaw them, which by itself takes 20 to 30 minutes, and issue them in a timely enough manner to avoid getting behind. It's simple. You're going to have red cells that are ready in just a matter of a few minutes, and if the plasma takes significantly longer, you're going to be behind, and you're not going to get that 1-to-1 ratio. Now, to be fair, there's debate back and forth about whether the 1-to-1 ratio is even most appropriate, but we're going to talk about that next week. So let's just leave that there for now and not argue about the 1-to-1 thing. But you also have to remember, in terms of inventory management, that frozen plasma units actually expire 24 hours after they're thawed. So as a result of that, the fact that it's hard to go just from frozen plasma to ready to transfuse in a short period of time, and further, once you thaw them, you don't have a long shelf life. Transfusion services have started to use a non-licensed product, which is called thawed capital P plasma. Thawed plasma, just like with liquid plasma has a capital P, thawed plasma has a capital P. And that is used to basically fill the immediate needs. Thawed plasma is not complicated. It is just fresh frozen plasma, or FFP, or plasma frozen within 24 hours after phlebotomy, which is a lot of the plasma transfused in the United States today. It's called PF24. So either FFP or PF24 that has been thawed and has reached its normal 24-hour post-thaw expiration time, it can be relabeled and kept refrigerated at the same temperature, 1 to 6 degrees, for up to 5 days after it was thawed. Some people call it 5-day plasma. It's especially clinicians tend to refer to it that way, I should say. Now, that 5-day window to transfuse a plasma product will just allow transfusion services that are serving trauma patients to keep plasma thawed at all times so that it can be rapidly issued in an urgent situation with less chance of it expiring. Don't get hung up on the fact that it's not an FDA licensed product. FDA has essentially decided that they're not going to make an issue out of it, and people use it all over the United States. Now, everyone knows that coagulation factors are going to decline in thawed plasma. There's no question about that. And that's true, especially for factors 5 and 8. Both of those drop by about a third to a half or so by the end of 5 days, but the residual activity is still considered sufficient for the acute needs. Again, just acute needs in emergency resuscitation. You're not going to use thawed capital P plasma for a long period of time. You're going to get the regular FFP or PF24 thawed, and that's going to be your primary first choice product. But even with that 5-day window that is allowed with thawed plasma, what we have really discovered is that transfusion services in busy facilities may still struggle to keep enough plasma immediately available. And further, smaller facilities that have fewer trauma cases, they may struggle with expiring thawed plasma on the shelf just because they didn't have an urgent need during that 5-day period. So as a result of that, there's been increasing interest in some kind of a product that would allow for a longer liquid storage state, and ta-da, enter liquid plasma. Well, so the obvious advantage of liquid plasma is that it has a very long shelf life as compared to thawed plasma. Obviously, it's sitting there in liquid or ready to transfuse form, and it gives transfusion services a whole lot more flexibility in managing their plasma inventory. However, that benefit does not come without some costs. You would imagine that if thawed capital P plasma has a significant decrease in coagulation factors at day 5 after thawing, that liquid capital P plasma probably has even a more substantial decrease, wouldn't you? You would definitely think that, but actually, surprisingly, not so much. The few studies that have been done, and I have to emphasize few because there haven't been all that many, they do show that liquid plasma at 26 days has roughly the same factor 5 and 8 levels as thawed plasma at 5 days. There have been a few studies actually comparing the effects of the two products, and actually there's been some suggestion in the surgical literature that liquid plasma may be even better at stopping bleeding than thawed plasma. There's a lot of debate and discussion about this, and really we don't have large clinical studies. And honestly, I don't know that we ever will. One other thing about liquid plasma that you should be aware of, and that's because it is never frozen, it is a product that at least theoretically has viable lymphocytes and could cause transfusion-associated graft-versus-host disease in a susceptible recipient. But that's unlikely to be the case in a trauma setting. So my perspective on this product, D, my friend, is that it's just fine. And it will do what you want it to do as long as what you want it to do is just bridge a gap between the immediate urgent plasma transfusion needs and support with freshly thawed plasma products, which are the more appropriate product long term. I really would not recommend using the product beyond that initial window between the arrival of the patient and the time to thaw the FFP or PF24. It really, before you do this though, it's essential that you have detailed conversations with your trauma team. Don't spring this on them. You can't do that. As far as using Group A liquid plasma instead of Group AB plasma, I didn't really address this in the answer, but I have addressed this in a previous blog post. Just go to bbguy.org/blog and check out the Breaking the Rules blog post from April 2016. And the next question comes to us from Florida. Ed from Florida writes, I had a 27-year-old patient with lupus who had a 2 to 4 plus positive autocontrol and a positive DAT with both IgG and C3b/C3d. The cross matches were compatible using low ionic strength saline or LIS all the way through the AHG phase. I have two questions. If a warm autoantibody does not have any specificity, is it okay to just transfuse any ABO compatible units? And number two, if that warm autoantibody does have specificity towards something like anti-little e or anti-big C, any RH antigen or any other antigen like anti-JKA, should you only transfuse units that are negative for that antigen, or is it okay for the patient to receive any unit that is cross-match compatible? Well, Ed, those are great questions, and I will be glad to help to tell you what I believe, and I'll give you my interpretation of the data, but you should really understand that there are sharp differences of opinion on this among different blood bankers, and you need to work with your local medical authorities to determine the best course of action for you in your particular facility. So with that caveat, here's are my thoughts on your two questions. First, when you see a patient with a warm autoantibody, I really think that there are several things you should be asking yourself right off the top. The questions that I always ask myself first, they're not the only questions, but the first three I should say is this patient hemolyzing? Number 2, is the patient going to be transfused? And number 3, perhaps the most important, is there an underlying alloantibody? In other words, if I have an autoantibody, antibody against someone's own red cells, do I also have an alloantibody? That last question is super critical because I see people missing that question really all the time. In your case, you told me that the cross matches were negative, which is great, but what you didn't tell me is what you did in between the steps of when you've got someone with an autocontrol positive. I assume that's from an antibody panel and a positive DAT, but you didn't tell me what you did in between, and that's a really critical step. So let's talk a little bit, before I get to your first question, about warm autoantibodies. Warm autoantibodies are generally very broadly reacting antibodies, which means that they'll attach to red cells from virtually every single donor. And we'll talk about some of the exceptions in just a second. And they will make all red cells incompatible. So regardless of whether a red cell is Rh positive or Rh negative, an autoantibody, for example, will agglutinate both of them. It'll be incompatible with both of them. As a result of that, if you look at an antibody screen, which you didn't mention, but I assume was positive, and an antibody panel, you'll see just across the board reactivity, which is usually fairly uniform against all the testing cells. In other words, it'll look like there's nothing compatible with this particular patient. It's not only possible, though, but it's also common, about 30% or so of cases, for patients, in addition to that autoantibody, to have underlying alloantibodies, the antibodies like anti-big K or anti-JKA or anti-D or anti-little c, etc. And unfortunately, with the pattern of the autoantibody reacting against all the cells, you just can't see that underlying alloantibody. So here is a key take-home point. It is essential to rule out alloantibodies in these patients before you make any transfusion decisions. How you do that is a topic for another day, but it will typically include things like autoadsorption, and you can look in the Blood Bank Guide glossary to find that and to find exactly what an autoadsorption is. But an autoadsorption basically removes the autoantibody and allows you to evaluate the leftover serum or the adsorbed serum for alloantibodies. If you find an alloantibody, then obviously from that point you would avoid transfusing units from donors carrying that target antigen as much as you possibly could. Now, if there are no alloantibodies, and I assume that that was true in your case, though you didn't say it specifically, it's probably most common practice to transfuse people with warm autoantibodies off-the-shelf ABO-compatible units. And that's the question that you asked. You said, if a warm autoantibody does not have any specificity, is it okay to transfuse any ABO-compatible units? And the answer is, generally speaking, yes, though some people choose to go a little bit beyond that. Most people will use what's called the, I hate this phrase, least incompatible or most compatible method. Basically, the blood bank cross-matches multiple units of ABO-compatible red cells and chooses the one with the least incompatibility or the most compatibility, if you prefer that. Realistically, that strategy, which doesn't really apply in your case because the cross-matches were compatible, but that strategy really doesn't do anything for anybody, to tell you the truth. It hasn't been shown to be predictive of the red cell survival. And honestly, one thing I really want to point out is that people who try and use that without doing the other step that I told you about, in other words, ruling out alloantibodies, if you just say, oh, look, I have a warm autoantibody, and then use least incompatible, you are making a mistake. You need to make sure that there are no underlying alloantibodies. Anyway, I'm sorry, I'll get off harping on that soapbox. There are a growing number of centers that have really looked at the data showing that people with warm autoantibodies are very likely to form alloantibodies, as I told you, about 30% or so of the time. And many of those centers have decided that prophylactically transfusing patients with warm autoantibodies, units that are matched for the major Rh antigens, big D, big C, little c, big E, and little e, and the big K, or the main KEL antigen, is a reasonable thing to do for those patients. In other words, for example, if a patient is big K negative and big C negative, you would avoid giving that patient big K positive and big C positive red cells. Now, some other facilities go even further, and they add KIT and Duffy matching to that mix. But in the end, I think that at least the Rh and KEL matching is perfectly defensible and reasonable. But again, different centers feel differently about this. Now, the second question that you asked is, what about autoantibodies that show specificity? What do you do with those? And that really, again, there is some disagreement on this. But in my view, the decision on whether to give antigen negative units really depends on whether or not the antibody has relative or absolute specificity. Let's talk about relative specificity first. It's very common for warm autoantibodies to react more strongly against certain Rh antigens, for example, than others. And it can do this with other antigens as well, but it's most common within the Rh system. However, if everything is reactive, if, in other words, it's completely reactive across the board, but the reactions are just somewhat stronger against a particular Rh antigen, like big C, little c, for example, that is what we would call a relative specificity. And the data so far does not really show any benefit of giving antigen negative units in that situation. In other words, the red cells seem to survive the same, regardless of the presence or absence of that target of the relative specificity of that warm autoantibody. In fact, actually honoring those can be a big mistake in some cases, in my view. I saw a case recently in my reference lab with a warm autoantibody with a relative big E specificity. And I was asked by the hospital if they should give the patient big E negative red cells. I thought about it for a minute and I said, well, wait a minute, is the patient little e negative? And the answer in this case was yes. So I think that it wouldn't make a whole lot of sense to immunize the patient to an antigen they lack, especially something like little e, this very high incidence, in order to avoid giving them a red cell which carries big E, which is just a relative specificity anyway. It probably doesn't matter. Now, in the case of an absolute specificity, the answer for me is a little bit different. Warm autoantibodies that react only when a particular antigen is present, again, that usually happens in the Rh system only, those are often and usually honored by blood bankers. And really, again, from my perspective, it makes sense that we do that. Giving the patient units that are negative for that specific antigen, again, there's not a ton of great data on that, but it's considerably more justifiable in my view. But you should also realize that many of those antibodies may not actually be warm autoantibodies, as we're discovering more and more variant antigens both in and out of the Rh system that can induce alloantibodies that just look like autoantibodies. So short answers to your questions, Ed. If a warm autoantibody does not have any specificity, is it okay to transfuse any ABO-compatible units? The answer is yes, but some people go a little farther than that with Rh and big K matching. And second, if there is a specificity, what do you do with it? Well, the answer is if it's relative, you typically don't honor it. If it's an absolute specificity, you will usually try and give antigen-negative red cells. But again, those answers may vary from medical director to medical director and facility to facility, so check your own facility for that. Okay, I think we have time for one more. This one comes from a transfusion service director in California who writes, I have a question about directed donor blood. If the product is not needed for the patient, can the unused unit be placed back on the shelf and used in the general inventory? Well, I could answer this question in one word. By the way, it's yes. So I could do that, but let me talk just a little bit about directed donations. Honestly, it's not my favorite topic because I'm not a big fan, but let's just take a minute to go through what the regulations say before I give you that one-word answer in a somewhat louder voice at the end. So directed blood donations, which are also sometimes called designated donor donations, are simply those where a patient or the patient's family just chooses their blood donors. They're theoretically used for situations of specific urgent medical need, but in reality, they can be requested just when a patient simply is a little freaked out about receiving blood transfusion from the general donor population. In my experience, directed donations are usually an educational issue, and a detailed discussion with a patient about today's risks of transfusion will usually lead to the request being canceled, but that's not always true. And honestly, it's a very emotional issue. And I would not be being honest if I didn't tell you that many blood bankers feel that this is totally great and totally fine. Not all by any stretch. I had the experience not too terribly long ago of sitting across from one of my peers. I respect her enormously. And we were debating this very issue. We were doing it in front of some residents and she didn't agree with me. She told me basically that I needed to be a nicer person. She's probably right about that. Anyway, there are certainly cases, though, where directed donations are indicated, no doubt about it, such as a patient that has a rare blood group who's made an antibody against a very high-frequency red cell antigen, for example. The antibody can make nearly everyone else's blood in the world incompatible, but just by simple genetics, the patient's siblings would have about a 25% chance of being compatible. So don't take me wrong. There are certainly instances where directed donations are logical and make sense. And if you really think about it, things like HLA-matched platelet donations are in a way directed donations. But I'm really talking more about the family member requested type of directed donations here. Anyway, so back to the issue. So when a directed donor blood unit is requested, it generally requires a clinician to write an order for the blood. They have to tell the transfusion service and the blood center how many units they need, what kind of products are needed, usually red cells, but sometimes we'll see plasma, platelets, and occasionally whole blood requests as well. And they also need to tell us when the product is needed. A blood center will typically require that their medical director approves the request as well, and that's where I typically come in as a blood center medical director. Now, if everything is acceptable and you decide to proceed, the directed donor or donors will be screened in exactly the same way that regular or volunteer or allogeneic blood donors, as we also call them, all three of those words are synonyms. We screen them exactly the same way as regular allogeneic blood donors. They're asked the same questions, they're given the same screening examination, and their blood is tested in exactly the same way as regular blood donors. In short, a directed donor has to meet all of the same requirements that a regular donor has to meet, with the possible exception that they may be allowed to donate more frequently in order to meet that urgent medical need. But that's really the only difference. So since all that is true, since they're screened the same way, examined the same way, answer the same questions, tested the same way for infectious diseases, the short answer to your question is yes, absolutely. If a directed donor unit is not needed for the intended recipient, it is totally okay to use that product in your general inventory for transfusion to other recipients. No problem, A-OK, good to go. You should be careful, though, because the same is not true for autologous donations. Someone donating blood for themselves, that rule is not the same, because autologous donors do not answer the same questions necessarily. Usually they don't. They're not necessarily tested in the same way. So you don't get a free pass with autologous donations. They have to be used unless it's an absolute desperate emergency for just the person who donated the blood. But with directed, yeah, you have much more freedom with that. I should note, again, that there may be some struggles with your computer system with that and with your billing if you do so, but those are things that you'll have to work out and address at your particular facility. Okay, that's it for this Ask the Blood Bank Guy Mailbag podcast. I hope that you've enjoyed it. I've had a good time. Please send in your questions for the June Ask the Blood Bank Guy podcast session. I'll be recording that the week after Memorial Day in the United States. In other words, between May 31 and June 3 will be the recording. So you can send in questions through the Blood Bank Guy website. That's at bbguy.org/ask. As well as through Facebook and Twitter, and just use the hashtag AskBBGuy. Again, I hope this has been fun for you. I hope it's been useful. Please let me know. Give me feedback on the BBGuy site or on iTunes if you'd like. As always, as you go through your day, I hope that you smile. I hope that you have fun. And above all, never, ever stop learning. Thanks very much, and we'll see you next time on the podcast.